So, as you know, I'm Wendy. I'm from Mayo Clinic, Arizona, and today I would like to talk to you about our journey with SGRT and discuss our implementation process. So just a little bit about Mayo Clinic. We first started radiation oncology in 1989. Our proton clinic opened up in March of 2016. We currently have 4 proton Hitachi ProBeat half gantries. We will have 2 CT on rails. Right now we only have 1, and we're in the process of installing our second one right now. We have 3T CT simulator rooms, 4 variant true beams, and an HDR unit. At the time I made the slides, we only had 15 physicians, but now we're up to 16. Our 16th one starts, I think, next month. And when fully staffed, we have over 50 therapists, and that's both photons and protons together. And our proton clinic treats from about 7 a.m. to 6:30 p.m., so they'll average between 50 to 80 patients. And then our photon side typically treats from about 7 a.m. to 4:35-ish p.m., and we treat anywhere from 80 to 100 patients on our photon side. So I have no disclosures. And the agenda today and our learning objectives are how we transition from a multi-vendor system to a single vendor, how to increase the staff engagement, how to implement an SGRT system, what sites we started with, and what our future goals are. So SGRT implementation and challenges. So our proton clinic commissioned our very first TrueBeam in 2016. We were super excited about its new features, and one of those features we were interested in was the capability of SGRT. And at the time it was known as OSMS, white label for vision. But the photon team quickly discovered that it was not a good fit for us in its current state. It had active monitoring only, so the beam would turn off when it went out of tolerance. It was very hard to override if we didn't want to use it, and the user interface was not very friendly. And so with the limitations at the time, we decided that it did not add a benefit to the patient or the clinic, so we decided to actually wait. So then what changed? Well, fast forward to 2017, the interest of the therapists started to increase towards SGRT. We were hiring new staff that had a lot of positive experiences with Align RT. OSMS had transitioned to having Vision RT trainers, and we had updated our old system to the new Align RT system version. Our department then wanted to transition to an open face SRS mask and utilize HyperArc for treatments. So then Vision RT had implemented the upgrade that provided a better all-around experience, and this upgrade improved the user interface. It implemented an auto-authorize feature, and it works seamlessly with the TrueBeam, and the postural video allowed the therapist to set patients up easily and quickly. But honestly, the main change that helped make the jump from not using the system at all to really loving it were the trainers. They provided us with some amazing hands-on training at their facility as well as on-site training. Since Go Live, we have had a Vision RT application support specialist actually come on site about every 4 months, and then they hold refresher sessions with the therapy team. And during that time, they review our workflows with the team, and they help to find ways to further streamline our processes. So the first couple of years that we used Align RT and photons, we were pretty passive with it. But once we introduced HyperArc, that paved the way for us to feel a lot more comfortable with the system. The first site that we used SGRT with were our SRS patients with HyperArc and the open face mask. And then with Align RT and HyperArc, we simply we took the cone beam, we aligned, and we would start treatment. But if the patient moved out of tolerance, we would stop, re-image, and align, but that really happens very little. The therapists have also reported that there is a significant improvement on the patient's initial setup. So with the old system, with the mask, they would sometimes have to max out their pitch and roll and yaw in the initial imaging, but then when they would go to the next couch angle, they would find themselves needing to adjust the patient, rotating the table back to 0, and then reposition the patient again. So with the open face mask and SGRT, the patients are less claustrophobic, they're more comfortable, and they fit super well into their mask, and that allows them to hold still better, and it results in less imaging, repositioning, and shorter treatment times. So once they were comfortable with the SRS treatments, they started to introduce other sites to SGRT, such as the breast, thorax, spine, and pelvis. And SGRT has allowed the photon side to go tattoo-less for many of their sites. So, but what about our proton side? So our proton clinic opened up in 2016, and that was the introduction to a whole new world of treatments for me and the other therapists that opened the clinic. We had wonderful half gantries, robotic couches, and that meant that our table was going to kick back and forth for every patient, and we were going to need to verify that the robotic couch was moving to the correct position since it didn't rotate on an isocenter like a traditional Linac does. And the only way for us to verify that the couch positioning was correct was to x-ray with every single movement. So we knew that it would be great to find another way to verify the couch, and so they started to look at SGRT systems. So at the time that physics was looking for the new system, they knew that we didn't love OSMS at the time, so they decided to try CRAD in the proton clinic. We installed CRAD in just one of our 4 proton rooms to start with so we could trial it out. We did have an issue though, so we used masks for almost every single setup in protons, and SGRT needs to be able to see the patient's skin surface to help with positioning. Our brains, head and neck, breasts, thorax, spine, pelvis, except for prostates, they all used a mask. So initially we used the system very little, but in 2020 we started the process of treating breast maskless, and we utilized SGRT for those treatments. The system helped us correctly position the patient, and it allowed us to make sure that the table rotated correctly. So with successfully treating breast maskless, we knew we wanted to start looking into other sites with either a partial mask or maybe fully maskless if we could convince physics. And to also use the SGRT system to assist us with verifying the couch rotation and reduce overall imaging. But to do so, we needed an SGRT system not just in one room, but in all of the rooms. And did we want it to be CRAD or did we want it to be Align RT? So when we considered how we wanted to move forward with SGRT, we started to analyze what worked well and what would we like different for each system. So to start off with Align RT, the daily QA was super fast. It was easy. It only took about 5 minutes. And then the importing process was also really quick. That only took about 5 minutes as well. When it came to positioning, the therapists are able to easily click between the surface, the deformation tabs, and the video all at the bottom to help analyze the patient's position and to help determine how the patient needs to be adjusted for the optimal alignment. But honestly, the favorite feature of the staff was the postural video. So the peak outline shows the therapist where they need to be so that they can easily adjust the patient as needed. You can see the 2 images on the left have a yaw that needs to be adjusted. The top right image shows the phantom aligned properly with the postural video, and then the bottom right video is a little stuffed bear who they call Mr. Stuffy Bear. And phantoms are typically hard and they have no give to them, whereas Mr. Stuffy Bear has give to it. So this helped to show the deformation, and it showed how the body may differ daily. And then here they used it to show the head position had changed slightly. So when looking at CRAD, the daily QA was very quick and it took about 5 minutes. CRAD does have real-time patient monitoring with 2 images that overlap, and the system was not as intuitive though as Align RT, and there was also a long lag after we would adjust the patient. Since CRAD is looking at such a large portion of the body, we tried to decrease that to see if that would help with the lag, but it still didn't. But it was something that the therapist also mentioned that it would take anywhere from 10 to 25 seconds to update for these lags. So that was a big downside of it. The importing process only took about 5 minutes depending on the site. The yellow box that you see, it tells the system what area that we're looking at and what we want to align to. And this box can be set before the patient arrives, so that's part of that 5-minute process. But it's fine-tuned on the patient's first day. So the therapists also have to adjust the time and gain of each of the 3 cameras so that the cameras can properly see the patient's skin surface. And these actually cannot be set ahead of time. You could guess, but you're going to have to tweak it when they get there. but that process can add approximately 5 to 10 minutes depending on the first day and if any troubleshooting's needed to be done. And then CRAD's treatment screen does have 3 main tabs: the patient selection tab, the setup tab, and the treatment tab. The setup tab overlays the 2 images, and it shows the black arrow to indicate which way the patient needs to move. And then the lights that project red or yellow light onto the patient's skin shows if the patient is too high or too low. And then in the image on the right, you can actually see that there's a red light on her chin, which indicates that she's too high. So the treatment tab is the third icon, and this actually tracks the timeline and the patient's movement. And then on the left side, the patient is lined perfectly with the images being green, and then on the right side, it shows a red vertical line indicating when the patient moved out of tolerance and how much, and then it also shows the chin in a red color, and it has the green image of where the patient needs to move back to. So why did we want one system? With having 2 different systems, we would have to double train staff. Staff needed a refresher when they rotated to one modality or the other modality. They expressed that they felt like they lost their skills when they were away from it for a period of time, since their rotations lasted anywhere from 3 to 6 months. And then the department would actually have to maintain 2 different contracts with vendors, licensing and service agreements. So we wanted to expand SGRT to all 4 proton rooms, but we needed to decide which vendor we wanted, CRAD or AlignRT. When we initially purchased CRAD, we were not utilizing the OSMS system due to the limitations, so that was the reason for going with CRAD. But then after AlignRT's upgrades, we discussed the pros and the cons of each system to help make an educated decision on what brand to use going forward. So the daily QA and patient importing was very fast for both systems on the first day, and VisionRT was easier to use. They did not have to fuss with the time or the gain settings. For daily utilization, VisionRT won this one as well, especially with the leg issues we experienced with CRAD after moving the patient. And when it came to saving time, VisionRT also won due to no lag and the ease of using the system. And then regarding tattoo-less, both systems could achieve this goal. So when we asked the therapists which system did they prefer, and I consulted with Appa, my Portuguese water dog, who is stuck at home with a spare human right now, we all agreed that AlignRT was the best way to go. So, staff involvement and training, since now we're going to introduce another new system to my lovely proton therapists. So now that we decided to install AlignRT into all 4 gantries, we started with the 3 rooms that did not have CRAD initially installed so that we could continue treating our current cases that were using CRAD. After we commissioned and did the training on the first 3 rooms, we then changed out the 4th room to AlignRT. We went live with AlignRT in April of 2024, and when we first started utilizing SGRT and protons, we were only using CRAD, and due to most sites using the mask along with the issues with having the system lag, we were only using it on breast and some CSI cases. So now that we had this fancy new system, how are we going to get the team on board with it? So it wasn't just another fancy wall art piece of equipment that they refused to use. We wanted to ensure that the therapists had a voice in the implementation. We knew that without this buy-in, they weren't going to like it. So we decided to have a total of 5 super users, and we sent all of them to training in New Jersey. We then held regular meetings with them to help develop all of our SOPs. And we used this time to collect feedback from the other staff therapists as well. And we found that regrouping and listening to what sites the team felt comfortable with starting with, that this was actually going to set everyone up for success. So our physics and physician groups were also very supportive of our plan as well. So the team did have a basic understanding of how SGRT works since they did work with CRAD, but they were still a little bit hesitant, and we decided to start with breast cases since we'd already been treating those, but then we, as well as CSI cases, but then we also decided to add in prostates. So we had already been using CRAD for breast and CSIs, and the prostate was new, but since we had so many prostate patients, and by utilizing AlignRT every day on this site, it would allow them to get more hands-on experience with the system. And these 3 sites were also sites that did not have masks. CSI does have a mask for the head, but we could use Align RT to help straighten the spine before imaging to help reduce the overall number of x-rays we would have to take for setup. And if we would have had other sites that didn't use a mask, we honestly would have tried it on a lot more sites. So after going live with those initial 3 sites, the super users were excited to try other things with vision. We knew open face masks were an option, and our boss masks are not a fan favorite due to the inability of the therapist to see through them, the rigidness of the masks, and the difficulty with fastening them to the boss board. But they do their job very well, and we do have a very low replan rate for head and neck and brain cases. So when we asked about changing the setup from the closed face mask to the open face mask, physics and the physician group were a bit hesitant. So we proposed doing an evaluation of the 2 open face mask types, and we would compare the findings against the closed face masks with similar disease sites. So we had a total of 10 open face head and neck masks and 11 open face head only masks, and we did a retrospective analysis of the number of resetups, the number of replans, and the setup issues. We also looked at image guidance, shift information that was exported from ARIA, and then this was analyzed in Excel for statistical significance using the student's t-tests. The calculations and assumptions were peer-reviewed by physics, and they found that only the lateral shifts on open versus closed long masks was found to be statistically significant or different with a p-value of 0.02. So their interpretation of the data is that the immobilization is not compromised by using the open-faced version of the mask. And after the evaluation was completed, the physician group did agree to transition to the open-face mask with the exclusion of paranasal sinus and chordomas, and our current head and neck setup currently consists of a Clarity head cushion, a Clarity bite block, and an open-face mask. So advanced techniques and future goals. Nope, I think I went too far. Nope, I didn't, sorry. All right, so the next step was to see what we could go tattoo-less with. So the physician, breast, and prostate groups did pose the question of going tattoo-less for their patients, but they were very supportive on waiting for us to gain more confidence in our skills before transitioning. So to take this next step, the SIM group continued to tattoo these patients, but the team was trying to ignore the tattoos and using vision to align the patients daily. We did have a couple cases in the beginning where we had to revert to tattoos, but after more training, we did find this was due to the ROIs needing to be adjusted, and approximately 9 months after going live with Align RT and Protons, we made the decision to go tattoo-less for both our breast and prostate cases. And then our Photon side had already been tattoo-less due to having the system in their rooms, a long, long time ago. So our current tattoo-less sites at Mayo, Arizona are the Photon breast, esophagus, thorax, standard spine, abdomen, pelvis, and prostates. And this does exclude SGRT cases with a mask, a prone rectum with a mask, and extremities. And then in Protons, we're currently tattoo-less with breast and prostate cases, and then you could also add pediatric cases to this list as well, because if it is a case where we would need marks on them, we use the temporary marks for the peds cases. We do have a written SOP for tattoo-less setups, including the SIM process and taking measurements from landmarks and documenting them in the setup notes in the instance there would be issues with the system on the day of treatment. But honestly, I can only think of maybe a couple times where we've had issues with the system, and that wasn't due to anything on Vision's end. It was due to our network issues. But we also do have a process for CT verification scans for tattoo-less patients that states that a patient needs to be marked by the treating therapist before their scans and CT SIM. So if you're not familiar with Protons, in Protons we do a lot of weekly verification scans, especially for head and neck cases. So we do have the CT on rail that I mentioned in one of the treatment rooms, and that's what we try to use for most of our VSIM patients. But in the instance that we're doing like a VSIM on a CSI, our table and our scanner The scanner can only move so low down the table, otherwise we risk colliding with the robotic couch. So that might be an instance that we would have to take one of our proton cases to the CT sim room. So anytime we have to do that, the therapists have to try to remember to put marks on the patient, and since that's not something that they do every day, it can tend to get forgotten. All right, so what's next? We still have the issue of continuing to image at every couch kick in protons. As we continue to innovate and refine our techniques, we are committed to enhancing the precision and comfort of our treatments. Our goal is to evaluate the frequency of how often we are applying shifts after imaging at each couch kick, ensuring that every treatment is as effective and efficient as possible. By using SGRT for monitoring all patients, including those with a mask, we are paving the way for future where every patient receives the highest standard of care. And together, we can achieve unparalleled accuracy and patient satisfaction, making SGRT an indispensable part of our journey towards excellence. And this is everybody that helped me, and I'd like to acknowledge them. But thank you, and I hope that our journey helps you in yours.